Policy Program at the New America Foundation. I want to thank you all for coming because we have quite a distinguished panel to hear from today. Basically, what we wanted to do was to try to make sure that people didn't forget about quality in this discussion of healthcare reform. You know, if you watch the national political media, they have room for one question on healthcare, and it's typically about coverage, or maybe if there's a follow-up on the way, sort of, and so how are you going to pay for this, right? Cost and coverage sometimes make it to the top, but quality isn't often mentioned. Yet those of us who do this for a living, and certainly the people that we're lucky enough to have brought to you today, know you can't separate cost, quality, and access. And when you think about it deeply enough, as some people do, you also can't forget the fact that America is unequal, that we have great disparities in access and outcomes and everything else in healthcare. And it turns out all these things are related. You know, we in America don't want to do comprehensive reform. It's such a big lift, and people say that people in this building can't do it anymore. It's just too big. But I would say it always reminds me of Winston Churchill, you know, when he said you can always count on the Americans to do the right thing after they tried everything else. We tried incremental reform so long, we failed. I think the people on this panel, and hopefully you will today, agree we can do this, but we have to do it together. Now, fundamentally what we want to do also is remind people that we have to talk about this reform process and set of issues in terms of what will affect the uninsured and the insured. And it is the quality issue that I think is most salient for the insured, and part of our challenge as a communication strategy going forward is how to make sure that insured don't feel threatened by the solutions for the uninsured, because as we will try to illustrate today, they are indeed quite linked. So I'm going to begin by introducing Christine Bechtel. She is the Vice President of the National Partnership for Women and Families. She also is the Vice President of eHealth Initiative, which is a nonprofit organization dedicated to improving quality, safety, and efficiency. So my guess is if she's Vice President of two organizations, she actually doesn't sleep. That would be my guess. She's been in Congress, worked with QIOs and quality, and began her career, I guess, up here with Senator Barbara Mikulski. So, Christine, thank you.
Oh, good. This thing's on.
Come up if you want. You can sit wherever.
Terrific.
I'm going to get out of the way.
Even better. Thank you, and good morning. I'll make a slight correction, which is I am actually Vice President of only one. Thank goodness. But it was a recent change, so I'm delighted to be with the National Partnership this morning. And I think I'm the only person on the panel who can't rightly be called doctor, so I'm thinking about changing my first name. Either that or I'm going to start sleeping in a Holiday Inn Express. Okay, so first I think it's a good idea to give you a little bit of orientation and ask you how many people have heard of the National Partnership for Women and Families. Okay, good. So there's a number of you, actually. A lot of folks actually know us for our long 35-year history in some workplace fairness and work policy standards. So I'll talk only briefly about that, but we've been around for a long time working on issues important to women and families. And we work here at the national level in DC, but we also work in a number of states and communities across the country with local consumer organizations on things like quality, health information technology, and leave policy like paid sick days. So you can see our priorities here. Historically, we focused on women's reproductive health and also, of course, workplace policies. Probably all of you are familiar with the Family and Medical Leave Act that provides 12 weeks of unpaid leave, right, job protected, to about 60 million Americans, and we were the organization that drafted that. So our priorities, though, now have a huge focus on healthcare quality, and you may ask yourself, of course, why? Well, it turns out that I think everybody knows healthcare is central to the well-being and economic security of both women and families. And it turns out that women suffer disproportionately from poor quality care. So escalating costs that stem directly from poor quality, which I'll talk about, are a big barrier for families. Women are more likely to suffer from chronic diseases, and they use more healthcare services, and they also face increasing disparities in healthcare. So this was our original lens. We've grown this portfolio, and we now sit on boards and bodies playing a leadership role in just about every national quality organization. So let me ask here, how many are familiar with the overall concepts in healthcare quality that you're seeing on the slide? Okay, so a number of you, but not quite all. I could give a 2-hour talk on this slide alone, and I think most of us on the panel could. So I'm going to go really quick, and good news is I'm a really fast talker. But let me just start with the fact that when we get health care, we have about a 50-50 chance of getting the right care for our condition. Medical errors are the 8th leading cause of death in the United States. Disparities in outcomes and in treatment approaches, and I think you're going to hear more from Marcia about that as well, are a tremendous problem. There's a lack of patient empowerment, which really centers on how well equipped we are to manage our own conditions. And we have a tremendous amount of variation in care. And I wanted to show you this slide. Some of you will have seen it before, but it is Medicare spending per beneficiary in hospital regions in 05. The darker areas are the higher spend areas. But if we overlay quality data on top of spend data, what we find is that indeed higher costs do not mean better care. And in fact, there's some evidence that it might actually mean worse care. So if you think about the fact that in Vermont, kids have tonsillitis, and in one area, 8% of those children are having their tonsils removed, but in another area, the same state, it's 70%. So we have a tremendous amount of variation that is a huge driver in the cost of healthcare overall. So we've got about 30%, the experts tell us, in the healthcare system that is wasted on this poor quality. So we clearly need health reform. We absolutely have to extend coverage to the uninsured, but we also have to ask ourselves, what is it that we're covering, right? Because poor quality affects everybody, regardless of insurance status. So we think that you have to address coverage, cost, and quality as a core package. They are all interdependent on each other, and they are all linked in a way that you can't do one without the other. So we think that every American should have access to care that is timely, safe, effective, and affordable. And what do we mean by that? Well, first of all, if you get your magnifying glass out, you can read the cartoon on the left is really about medical errors. So we want we want care that is in fact free from medical errors. And we want to be sure that every patient gets the right care at the right time for the right reason at the right cost. And it turns out that this is exactly what patients, read voters, also want. So we think that there are 5 essential areas in health reform that we must tackle to improve quality effectively. And I'm going to, again, I could talk for like 2 hours on that, but I'm going to go quickly through each of these areas. And then you're going to hear more detail from the rest of our panel on some really fantastic work that they've been doing. So one is enhancing access to primary care. We know that primary care helps people stay healthier. We know that it improves their experience with the healthcare system, which is feeds into patient empowerment and more effective self-management, which is one thing we're all asking patients to do, and it reduces overall health spending. So we think a very promising model is the patient-centered medical home, and we're leading a national coalition of consumer groups to really bring the patient voice to ensure that it is in fact patient-centered. We believe that you have to measure quality, you've got to report the results, and you've got to reward high performers. We have to bring healthcare on par with cars and toaster ovens. We have to know more about what we're getting out there. So it also means that we've got to redesign the payment system. We have to learn how to reward those who do better and not those who do more, which is how we currently pay for healthcare under the fee-for-service system. And in fact, we think it's so important that we're leading consumer organizations at the local level in about 17 different communities supported by Robert Wood Johnson to really push for, at the local and state levels, this kind of transparency and accountability. We think health IT is a critical cornerstone in all of this. It'll, as you can see, the top picture will help eliminate handwriting errors. Anybody want to take a gander at trying to read that prescription? Yes, right? Can
wow.
You turn, you know what? I have to say, nurses are my favorite because they go, I can read this crappy handwriting. Yeah, that's not Coumadin, which is a blood thinner. That's not in fact Coumadin, that's Avandia.
And you never get CRN.
Right? So it's really something. So anyway, so we think it's not just, of course, about eliminating handwriting errors, but also about making sure that clinicians have the right information on the right patient when they need it at the point of care. But it also is a way that we get better quality data for public reporting so that we can move from not just claims-based reporting, but also getting the more rich clinical data that we can get through technology. Empowering patients is critical. We are currently already asking patients to recognize and demand high-quality care, to make better healthcare decisions, and to be full partners. But to do that, they really need to be better equipped. They need information on cost and quality. They need better benefit design so that they can make decisions based on value in their own lives. They need care that is culturally effective and linguistically appropriate, and they need to participate in shared decision making. And then finally, we have to know what works. For us, this is comparative effectiveness research. There are a lot of treatment approaches and technologies that are coming to the market every day that are real advancements in patient care. But some of them are just more expensive, but not necessarily more effective when it comes to improving patient outcomes. And so we believe that we need independent evidence so that both patients and clinicians can make better choices about what works. So I want to leave you with just a couple of thoughts here. One is, of course, that health reform has to address quality, cost, and coverage. That they are absolutely interdependent and they are central to the economic security of women and families. We've got to redesign the payment system to shape a better system that delivers cost and quality. And we're going to encounter a lot of resistance along the way. I think those of you who survived the 93-94 reform debates will know that. Those of you who were in junior high school at the time, you'll learn about that. But we have to remember, despite the resistance that occurs, that healthcare quality that is patient-centered must be the guidepost and central tenet of those reform debates. So thanks for having me today, and happy to take questions later.
Right.
Thank you.
Thanks, Christine. Not only was that a wonderful overview and introduction to the issue, but we were actually under time, and I forgot to say, 10 minutes tops, so she gets a picture. And the nurse, thank you very much. I just love that Kundan from 27 feet. That's wonderful. Our next speaker is Dr. Brent Asplund, who has been working in quality issues in emergency departments for some time and how they impact our ability to get care. He not only runs the emergency department in a hospital, I guess it's Regions Hospital in St. Paul, but he's vice chair of the Department of Emergency Medicine at the university. He's on the IOM committee for emergency departments a few years ago, and there's no one better qualified to speak about these issues. So, Dr. Brent, come on up.
Very good. Good morning. Thank you, Len. Appreciate that. It's a pleasure to be here. And I want to give you a perspective from what I call a room with a view. The emergency room, I think, really has a unique perspective on what works well in healthcare, what doesn't work well in healthcare. And I want to take you through a few areas, again, focusing on the perspective of quality. Actually, could I have some of yours? And I'll start with this. The Institute of Medicine report back in 2006. I don't know how many of you are familiar with this, but there were 3 reports released in June of 2006. One focused on hospital-based emergency care, and the subtitle of that report is listed on the slide, At the Breaking Point. And the other 2 reports focused on EMS and pediatric emergency care. But if you want to look at why the emergency care system was characterized by the Institute of Medicine as being at the breaking point, this slide really sums it up. Between 1993 and 2003, emergency department visits grew by over 26% annually. They're now over 115 million. People believe that the 2006 NAMSES data is going to be closer to 120 million. But at the same time, the number of emergency departments across the country dropped by over 400. And more importantly, almost 200,000 inpatient hospital beds were taken out of service. So you have more people coming to fewer emergency departments with fewer places for those patients to go, especially the most seriously ill and injured patients. By far, the number one quality concern in the emergency care system in 2008 across the United States is the problem of capacity in our hospitals that leads to crowding in emergency departments and diversion of ambulances. And the effects of this practice environment and the challenges on our patients are really quite profound. The biggest problem that has been pointed out not only by the Institute of Medicine reports, but also by the GAO in their report in 2003, is the delay in moving admitted patients from the emergency department into hospital beds. And that delay, in some cases, can take hours, and in other cases, can take days. Other findings, again touching on quality of care concerns from the Institute of Medicine report, looked at lack of coordination of care across the emergency care system, fragmentation of handoffs of care, etc., a lack of system accountability for performance, and patient safety concerns. Much of what we know about medical errors from the To Err is Human report and Crossing the Quality Chasm, those original studies clearly have shown, not surprisingly, that the emergency department is one of the highest risk areas in our overall healthcare system. And the effective errors are more likely to lead to patient death if they occur in the emergency department. That's rather intuitive, but nevertheless, it's an important data point to keep in mind when you're thinking about quality issues as they relate to the emergency care system. So those are some of the numbers, but why do we keep seeing cover stories like this? And I think it's important that it's not just 115 million visits, it's 115 million different patient stories that really point out this problem in a more compelling way, I think, to really understand how it affects everyone, not just the uninsured, everyone who needs to access the emergency care system. Grady's Hospital in Atlanta, over 100,000 patient visits, the level 1 trauma center for the city of Atlanta. They have a huge emergency department, but to count and take care of their boarding patients who are waiting for inpatient beds, they ran out of rooms and had to number hallway spaces across their hallways of their emergency department. They ran out of hallway spaces and had to add letters so that they could keep account of more than one patient in each hallway space. They've had as many as 70 inpatients waiting for inpatient hospital beds. One patient story, patient comes in respiratory failure, gets intubated, put on a ventilator, goes in line for an intensive care unit bed. Stays overnight, improves, actually the next day was extubated, taken off the ventilator. Well, now they don't need the intensive care unit bed, so they get in line for a step-down bed. Continues to wait for a bed in the emergency department, improves to the point that ultimately they get in line for a general care bed and get discharged from the emergency department, having completed their hospitalization and never leaving the hallways of the emergency department. I want to make it also clear that this problem is not limited to large urban public hospitals. It's clearly the case that this problem exists to different degrees with different local unique characteristics across the entire country and affects private and public hospitals, trauma centers, and non-trauma centers. In Minnesota, we're fortunate that we have not had as big of a challenge with medical patients, although we certainly do have capacity challenges. In Minnesota, it's psychiatric patients and the ability to move them to inpatient beds. And it's not limited to Minnesota, it's across the country. Earlier this spring, on Saturday morning, I came in for an 8:30 a.m. shift, saw a 72-year-old gentleman who had been seen 2 hours before my arrival and was waiting for a geriatric psychiatric bed, depressed, suicidal, with multiple medical problems. This was Saturday morning. His length of stay in our emergency department was about 3 hours. When I arrived for my shift, I left at 4:30 on Saturday afternoon. He was still waiting for a psych bed. Came back for my 7 a.m. shift on Sunday. He was still there. Went home from my shift on Sunday afternoon. He was still waiting for a psychiatric bed. On Tuesday morning, ironically, the Institute for Healthcare Improvement was at our hospital for a meeting on patient flow. And I checked our tracking board right before I went into that meeting, and the 72-year-old gentleman was still in our emergency department on Tuesday morning. His length of stay at that point was around 75 hours in our emergency department. This is our tracking board at Regions. At the time, we had a 35-bed emergency department. This is almost 2 years ago. Since you can't see these numbers, the one column here is total treatment time in the emergency department. All but 3 of these patients are waiting for psychiatric beds. And I'll quickly run down. 8 hours, 9 hours, 20 hours, 13, 14, 16, 17, 23 hours, 43 hours, 60 hours, 24 hours, 25, 25, 25, 14, 11. That's the total number of hours cumulatively from these patients. The peak number of patients we've had waiting for psychiatric beds is 27. The longest length of stay in our emergency department is 5 days. I've heard of a length of stay of 14 days in the Northeast waiting for a psychiatric bed. So these are the characteristics that we're faced with in the emergency care system. And it's not just inconvenience and delays. New data are showing that these delays are related to you're less likely to get pain medications if you present with a painful complaint. You're less likely to get timely administration of antibiotics. You're less likely to get recommended therapies for acute coronary syndromes and heart attacks if you come in during periods of time where there's crowded conditions in the emergency department. So it does matter. As I mentioned, the ER, as I characterize it and many others have, is really a room with a view. If you look at your community and what's working well and what isn't, if you want to find out where there are quality and access problems, go to your local emergency room because those problems will show up there first. When I came to Regents in 2000, we never had patients sleeping overnight waiting for psychiatric beds. We knew there was a problem with psychiatric capacity before other parts of the system were aware that that problem existed. Malcolm Gladwell wrote a piece that appeared in the New Yorker back in February of 2006, which characterized the story of Murray Barr, a homeless gentleman from Reno, Nevada. And it told the story about how Murray interacted with the law enforcement system, the healthcare system, all the other social welfare systems, and how the system continued to do everything but actually just provide a home for Murray, and about all the costs that were incurred before he ultimately died. And a quote from that I think is very telling and relevant to our discussion today. Solving the problem of homelessness for people like Murray may well cost less than the money it took to ignore it. And if you transfer that to what we're looking at from a quality perspective in healthcare, I think it is a very apt, and many of the same concepts can be applied to what we're doing with healthcare in this country, particularly from a quality view. This is a perfect example of the Pareto principle, the vital few and the trivial many. And then the cost associated with taking care of this is fundamental to healthcare reform in America. George Halverson, who's the CEO of Kaiser, and George Isham, who's our Chief Health Officer at Health Partners, wrote this book, Epidemic of Care. And I think the next graph is probably the most telling graph for how we approach healthcare and healthcare reform in the country. It looks at the distribution of healthcare costs. 30% of all the dollars we spend in healthcare go to 1% of the population. That didn't transfer very well, but there's a graph that shows that very, very nicely. 20% of us don't spend anything on healthcare in a given year. Half of costs go to 5% of the population. With over $2.1 trillion in spending, that's what this looks like. Top 1%, over $200,000 per person. 5% is 70. The bottom 70% of the population, only $1,000 in total healthcare spending in a year. About 20% zero. So that's what that distribution looks like. And why would I bring that up as an emergency doc? Well, our delivery system, and this was characterized by Christine as well, is designed to produce volume rather than value. It's focused on hospital-centric care after you're sick, and it's aggressive care without regard to cost, even sometimes without regard to patient preferences. And that's what we see in this cycle in the emergency department about how we use our hospitals. Atul Gawande and Peter Pronovost looked at this perspective from an article that was called The Checklist, again published in the New Yorker. That's where I do most of my scientific reading. In December of 2007, and looking at 3 buckets of knowledge: understanding disease, designing effective therapies, things that we've done reasonably well, but making sure those things are delivered in a systematic way, what we fail to do in this country. And they call for a National Institute of Healthcare Delivery. We have a $30 billion NIH, which has been a remarkable powerhouse of discovery, but we have no $1 billion National Institute of Healthcare Delivery studying how best to incorporate those discoveries into daily practice. And if I could say one thing from an emergency department perspective, is that this really rings true every day. And I would look at this from a quality and value perspective as a Willie Sutton strategy. Why do you rob banks? Because that's where the money is. Why do you focus on the high-cost patients? Because that's where the money is in our system. And these are things that we can talk about and how that type of strategy went on full. Certainly the patient-centered medical home is an example of the top two, looking at restructuring outpatient care, focusing relentlessly on the high-cost persons, insured or uninsured, in our system, and looking at ways to make our hospitals safer, and looking at defining value in our reimbursement and payment system. Because I agree, until you change the payment system, you aren't going to actually see the delivery system change. Well, that graph that you can't see the first time, you still can't see, but I bring that back because it looks this way from an emergency department perspective. A very quick story. 42-year-old gentleman had gotten back on insurance 3 days prior to this emergency department visit, but had changed jobs and lost his insurance for 6 to 8 months, had been off his blood thinners and other medications, had a history of a pulmonary embolism, blood clot in the lung, and irregular heartbeat. Because he had not had his anticoagulants, he came back into our emergency department in atrial fibrillation with another blood clot in his lung, in distress, 3 days after he came back onto insurance rolls for his new employer. He gets hospitalized. A perfect example of what that high-end cost of the spectrum looks like and how we're not creating value with our care. So I would just close with a question, because I think, although I kind of went up to 50,000 feet after starting from a couple of stories in the emergency room, if you really want to look at whether we're making progress 5, 10 years from now with these issues, ask yourself what hospitals look like in 2015, or when we get there, what do we see going on in our hospitals? Who's in them, and why are they in them? And what happens to them as far as their care is concerned during their hospital stay? And I think this will be the most telling set of data that will tell us whether or not we're actually making progress with these quality and value issues in the emergency care system and in healthcare more broadly. I'll stop with that, and I look forward to taking your questions later.
Thank you, Brent. That was excellent. And so Marcia Regenstein is the Associate Professor, Research Professor at the Department of Health Policy, George Washington University. She's also the Associate Director of Aligning Forces for Quality, which is a new and very broad initiative funded by Robert Wood Johnson to take the quality in healthcare discussion at the regional level. And in particular, she's Project Director of Speaking Together, a program that has a focus on raising the bar in language services and reducing access to care. So Marcia, thanks for coming.
Thanks so much. Have to adjust for height differentials. Okay. Good morning, everyone. Thanks so much for having me here to talk about healthcare disparities and quality. So when we talk about healthcare disparities, which many of you have heard much about, I think about healthcare disparities really as a national epidemic that's causing an enormous amount of death and illness across the country. It's in all corners of our country, affecting so many different people in our country. So I think it's important to sort of just define what we mean by healthcare disparities. And luckily, the Institute of Medicine did a nice job doing that in their landmark report that was published in 2002 called Unequal Treatment. And the fact of the matter is that racial and ethnic minorities tend to receive a lower quality of health care than non-minorities, even when access-related factors such as insurance status and income are controlled. So most of us are really familiar with access-related disparities where people are uninsured or people are low income and can't access the services that others can. But the reality is that even when these factors are controlled, there are differentials in treatment options, there are differentials in outcomes. Others have mentioned that as well. Excuse me. And one of the areas where there's the most documentation about healthcare disparities is in the area of cardiac care. In addition, there's an enormous amount of information about the importance of communication in healthcare. And lack of communication or communication barriers also create problems in healthcare. Okay, so in terms of why could we focus on cardiac care when we're talking about healthcare disparities, this is just several of the reasons why cardiac care may be a good area to focus some activity to try to mitigate disparities, try to reduce gaps in care. So it's a leading cause of death. There's so much evidence talking about the disparities in cardiac care. There's also a fair degree of consensus about what it means to provide good cardiac care. And there are increasingly more and more measures that people are looking to use as a barometer for the way cardiac care is provided and what it means to get good cardiac care. It's also an area where hospitals and other healthcare providers are very comfortable doing measurement, looking at data, and seeing ways to improve care for their overall population. We don't really know exactly what's driving disparities, but there could be disparities associated with different providers, both within an organization, across organizations, and in different regions of the country. And there's a lot of evidence that's pointing to different reasons for disparities. But I think that the jury's still out on what really is driving disparities, and they may be different in different parts of the country, in different types of organizations. Likewise, there's lots of evidence about the importance of communication. We mentioned medical errors and patient safety. The Joint Commission considers communication one of the key aspects that's a driver in errors. And there's a lot of literature that shows that patients who don't communicate well with their providers just do poor. They get less care or quality care. They don't adhere as well. They're not as satisfied with their care. And so in terms of our own work at George Washington University, when we thought of ways to address disparities, we looked at these two areas in particular, saying what can we possibly do in the area of heart care and what can we possibly do in the area of communications to move the conversation away from just the problem of disparities and thinking about some solutions. So as we said, there's overwhelming evidence that suggests that healthcare disparities exist. There's access related, but there's also even for similar populations, similarly insured populations. There are thousands of studies that document not just cardiac disparities, but disparities across the board. But there are very few that really provide frontline providers and healthcare organizations with the tools and the strategies to be able to move the bar and really improve care. So that's what we really thought what the challenge was. How do you raise overall care, but at the same time narrow the gap between majority and minority populations? And majority and minority populations are not a stagnant term. They really depend on what the community is, what the provider is, and what the demographic characteristics of the population are in that particular area. So in terms of quality improvement, we were fortunate to be funded by the Robert Wood Johnson Foundation and try to develop some strategies for these improvements. And two programs have been working on this for the past several years. One is called Expecting Success, Excellence in Cardiac Care, which has a focus on cardiac care and improvement of disparities, improvement of care for African American and Hispanic patients. And another is Speaking Together, which has a focus on language services for improving quality for patients who have limited English proficiency. And both of these projects are working right now only in hospitals, but may branch out to other providers. So Speaking Together will be doing work in community health centers as well. And we chose a model of a quality improvement collaborative because it's a model that has worked with a lot of other healthcare organizations. It brings together resources and providers in a shared learning environment, uses data to track progress, and matches performance against some established measures of quality that are well accepted throughout the field. Now, in the area of language services, there were no measures, so we had to develop them. And in cardiac care, they're very well established, and in fact, they're reported publicly through CMS, and hospitals routinely look at these measures as at least one marker of quality for heart care. Another value that using a quality improvement collaborative had was sort of getting around the elephant in the room, which is it's very hard for people to talk about disparities. It's very hard for them to look within their own practice to even entertain the thought that their practices are disparate. Because all the providers that we interact with, all the physicians, nurses, staff, are totally committed to providing high quality care to everyone. and yet disparities are persistent. And so we said, well, let's use this model that's well established in other areas and just look at performance by the race, ethnicity, or language of patients and see whether we can identify some gaps in care and then develop strategies to improve. I'm just going to run through this quickly to get to some of the findings. So what you're looking at right now is one of the performance measurement outcomes from the Expecting Success Cardiac Care Collaborative. There were 10 hospitals that were chosen to work over about a 2.5-year period to work on their overall cardiac care. This graph shows performance on the 8 AMI, heart attack measures that are routinely reported to CMS. And what Expecting Success did was they bundled a measure of all the 8 things that CMS says. These are important in the delivery of care to a patient who is having a heart attack. So there are 8 different things. Did they get aspirin at arrival? Did they get beta blockers, et cetera, et cetera? Did they get smoking cessation? And they bundled it up so that what this basically said is, did patients get all that they needed with respect to heart care? And you only get credit if you get everything you need. And more hospitals are looking at sort of these all or nothing measures to provide really information about quality. What you can see is that at the beginning of this project, there was a lot of variation in terms of how these 10 hospitals were doing, with the lowest performer around 20%, a little over 20%, and the highest over 90%. Over the course of the collaborative, that gap began to diminish. And so what that meant was overall care was getting better across all of the hospitals, and that meant that more and more patients across this group were getting high quality heart care. Not only was overall care getting better, but the disparity between African American and whites were narrowing. So at the beginning of the collaborative, this is for beta blockers at discharge, one of the measures. At the beginning of the collaborative, about 60-some% of Black patients were getting what they needed in that area. By the end, it was nearly 100%. So again, what the project did was show that by working together and focusing on quality, by looking at data by race and ethnicity, by getting together teams of people in the hospitals to openly say, we're not doing as well as we should be doing with our Black patients in this situation. They came up with strategies to improve care, and overall care improved. This is information from the Language Collaborative, and this shows performance on one measure, which for my money is the most important measure, which says, if you have a patient in your hospital who says that he or she needs language services, needs to get care in another language, if they say they prefer care in whatever language, did you get them that care in that language? You can do it through a bilingual provider, you can do it through an interpreter, you can do it through a telephone interpretation, a video, however your organization chooses. But did you get it to them at initial assessment and discharge? Those are the 2 most important times, or 2 times along many important times that communication is essential. We started these are showing 2 hospitals. At the beginning, what they realized was that virtually none of their patients were always getting those services at assessment and discharge. They had interpreter services, they had no idea whether patients got them. By the end of the collaborative, again, by looking at the data, by looking at language, by getting teams together, by getting CEO support, they slowly worked their way up to targeting resources to need. Not only did overall quality improve, but this is a slide, it's hard to see. These show different languages, Somali, Creole, I think it says Portuguese, Vietnamese, and other. Some of the language were doing fine, others were not getting the care they needed in a timely way. By the end of the collaborative, now that they had that data, they were looking at it on a monthly basis, they came up with solutions to improve care. This is just another hospital that decided they'd love to be able to screen patients for depression, didn't know how to do that, got a team together, translated a screening tool into many different languages, and by the end of the collaborative, all the patients who spoke other languages in this clinic were screened for depression. So, you know, what makes this successful? I think linking real quality improvement to a disparities model makes sense because it frames the issue around practices that hospitals are really comfortable with. We've given hospitals and healthcare professionals tools that they can look to that are very practical. So if you don't make quality improvement and disparities reduction a practical enterprise with busy health professionals, it really can't take off. So there's sort of something in their hands they can work with. Also, using data is so incredibly important to be able to track progress over time. I just wanted to mention Aligning Forces for Quality, which is a very large, ambitious Robert Wood Johnson Foundation project that is going to take a lot of the pieces of these projects that we've worked on and add many others as well to apply, to go very deep in 14, eventually 20 U.S. communities to try to really move quality across a broad set of categories, so ambulatory care, hospital care, and payment reform, which is the long-term goal. Thanks so much.
Thanks, Marcia. Not only was that a great presentation, but you gave us some good news that there is some hope out there, and we appreciate that in the whole business. It's a nice thing. Our final speaker today before we turn to Q&A is Dr. Guy Clifton. Now, Guy is a professor of neurosurgery at the University of Texas Medical School in Houston. He's the founding chairman of the neurosurgery department and holds the Runnels Distinguished Chair in Neurosurgery. What that means is that Guy is a brain surgeon. So when you hear things like, well, it ain't brain surgery, Guy actually knows what brain surgery is. And I think it's probably true, he might agree, that healthcare reform is harder than brain surgery, but I'll let him tell you about that. I got to know Guy, and Guy, by the way, has also recently written a book, Flatline, Resuscitating American Medicine, which will be forthcoming in November, right after the election, when we're ready to turn to solutions. Guy was an RWJ policy fellow in Orrin Hatch's office, and that's how I got to know him. And I must say, I was so impressed when I met him because he basically said, you know, Lynn, I figured out I cannot solve Houston's healthcare system's problems in Texas. We have to do it here. So I was lucky enough, you know, on good days I can be persuasive. I was lucky enough to persuade him to join me and become an advisor to our program, and now he's an advisor to our nation. So thank you, Guy.
Thanks, Lynn. This will take 15 minutes, but no more, I think. You know, if you've read the papers this morning, we all tend to think that we go through our day-to-day activities, everything stays the same, we just do our job, nothing changes. That's not always the case. And so the reason I'm here is I practiced neurosurgery for 30 years, and everything worked pretty well. I had a great academic practice, grants, you know, all this stuff. About 2003 in Houston, I was chief of neurosurgery at probably one of the biggest trauma hospitals in the country. Helicopters, picture them flying over skyscrapers, dropping very sick patients in the middle of Memorial Hermann Hospital in Texas Medical Center. And the department, we built it, never turning a patient down, always, no questions asked. It was sort of built from ground zero starting in 1990. About 2003, we were turning down 50 patients a month. The bad news is they weren't getting anywhere else. They were getting in, but getting in very late. So we began to hear stories of people dying, preventable deaths. This is all still going on. It has now become sort of embedded in the practice of medicine in Houston. I mean, the docs are doing all they can do, but it's system failure. It's institutionalized system failure. Same thing's happening in Los Angeles and several places in California. That was one of the two big pushes behind the California effort at healthcare reform. So I'm here to tell you, and anybody that will listen, that numbers never lie, and these numbers will get to their inevitable conclusion. And I predict within a decade. One thing I did learn here is it probably is within a decade. The message is that there's going to be no embedded quality in medicine until there's a business case for quality in medicine. Right now, all of the financial incentives in healthcare drive actually for quality and volume. I was talking to a friend of mine in Houston who's a very successful restaurateur about all these problems. And he said, well, what's the problem? I said, well, we need more money for uninsured care. We have 30% uninsured in Houston. He said, wait a minute. You got hotels in Fannin Street, or hospitals in Fannin Street with lobbies that look like 5-star hotels. They're building 20-story office buildings. You're telling me there's not enough financing in health care? So I started looking, and, he was right. Let's see.
You keep going.
Going backward.
Oh, there we are.
There we go.
So I started looking, where's the money? I knew how I practiced. We never paid any attention to money. I calculated that I was single-handedly responsible for probably about $17 million in unnecessary imaging over the course of 15 years. Didn't do it deliberately, but I had to repeat studies of marginal quality. So I started looking at the medical literature and found this. You've heard the chronic disease story. It's about 30%. Inefficient hospitals, I don't have a number because I can't tell you. My guess is it's 25%. Estimates have been from 15 to 40% of hospital costs are pure waste. That's about 20. I did some work on unnecessary procedures, basically heart procedures, spine procedures, things that are either unnecessary or completely unproven value. And I was surprised to find it was only about 6% of hospital spending. That's a conservative estimate, but it's certainly no less than that. And then finally, unnecessary imaging. If you had any question, you did a study. We're finding now that there's so many CAT scans being done that radiation oncologists expected to increase the risk of cancer in future years. There are really no standards when you order an image. So those are the four sources of where the money is. How do you get it out and improve quality? I think about it in three ways. Establish benchmarks of quality. And when I talk about that, what I mean is outcomes. That is mortality rate, complication rate, and possibly length of stays, outcomes. Best processes. How did you do it? How did you get a lower mortality rate? How did you get decreased complications? What did you do to do it? And finally, share the savings. The payment system now, as you know, is fee for service. The more you do, the more you're paid. What if you paid providers more if they had lower mortality rates, lower complication rates, and shorter length of stay? This is what the current payment system looks like. The DRG, the Medicare payment for a patient admitted to a hospital with pneumonia, is 70% higher if that patient has a series of complications during admission, whether those complications are preventable or not preventable. So if you get a patient through a hospitalization admitted with pneumonia with no complications, you get paid 70% less. There is no business case for excellence in hospital care. It's even worse than that. In Houston, what they're doing right now, I found out last week, is one of the hospital systems has consolidated, so you can't do business in Houston without this system. They also care for about 15% uninsured. It's the hospital system I worked in. They are making money like bandits. They're printing it, and what they're doing is they have escalated the rates to private insurance, who is now paying cost plus, so that for every uninsured patient they admit, they're actually making money because they admit a private patient with it. The doctors not only don't see anything about their length of stay, complication rates, or anything else. I won't say the message is not to pay attention to it, but it is. Basically, nobody cares. Everybody's trying to do the right thing, but in a system point of view, there is no attention to any of these matters. Let's look at a hospital that did something about it. Why? They decided to do the right thing. It's LDS Hospital in Salt Lake City, and I went out there a couple of times to see what they're doing. It and Mayo Clinic are considered to be the two best hospitals in the country, both really doing what they do because they think it's the right thing to do. I talked to Dr. Klemmer there, and he explained how they had dramatically reduced the incidence of hospital-acquired pneumonia in their hospital, and they showed me through their intensive care units, and I talked to their nurses. This was no small task. It was a complete change in culture in the medical intensive care units in the hospital, involving information systems, involving nurse training, involving automated data collection, a lot of education. And one example is you see reduced blood glucose. You wouldn't necessarily think that having a normal blood glucose would keep you from getting pneumonia, but it does. I mean, nobody necessarily thought that, but that's what they found. And the trick here is if normally you keep a patient's glucose a little above normal or maybe a lot above normal because it's safe, If you drop glucose too near normal in a diabetic patient or somebody with high glucose, and it gets too low, they get an insulin shock and they can die. So it's much harder to keep a blood glucose at a normal level in a sick patient than to tolerate a higher level. But it turned out that if you tolerate a higher level for a number of days, the patients get pneumonia. You don't see it. It just, in a large number of patients, it becomes evident. In an individual patient, you don't know that. So they found these things out, and so the protocol they used involved a lot of insulin. The doctor could pull up the blood glucose of all the patients in all his ICUs over a period of 15 days in about 5 seconds and look at it. Somebody was watching it all the time. The nurses were all over this. So it was an entire change in culture. Well, guess what happened? They dropped the hospital-acquired pneumonia rate from 12% to 3%. Huge effect. Saved $5,455 a patient, $24 million a year, and turned every penny of it back over to payers. Because, guess what? You get paid cost plus, or based on DRG that pays more for complications, you lose money or don't make money when you make those kind of investments. What would a payment system look like? This is worth taking a minute. The American College of Surgeons has, I think, maybe the best quality program I've ever seen. It's extraordinary. They have risk adjusted. And what risk adjusted means is the data they will take on a patient admission to the hospital has about 20 different medical factors so that they can very precisely predict what the expected complication rate of patients would be accurately. The doctors all agree. So that line that is going this way is 500 hospitals. The line that's going, that line is the expected rate of pneumonia. And let's just say it was what LDS hospital had. Let's say it was 12%. So that line is a 12% expected rate of pneumonia. Those are 500 hospitals, and those are the observed rates of pneumonia, the actual. What this means under good, these hospitals had 0 hospital-acquired pneumonia rates from general surgical procedures, up to maybe here, 12%. Guess what here? 36% rate of hospital-acquired pneumonia in the bed. That's 1/4 of the hospitals. Now, I will tell you that in terms of best processes, nobody knows what these hospitals did. It was different from what those hospitals did. And that's something we want to know. What if you set up a payment system where you paid a lump sum based on admission for right there, or maybe even right here? These hospitals that had up to a 15% pneumonia rate get paid a pretty good profit margin based on their labor inputs for that kind of care. What would happen to those hospitals? They go out of business or lose money or change. And what they're finding, the American College of Surgeons, that within 2 years of giving hospitals this kind of information, they move to a better category. You give the docs the data, they fix it. How they're fixing it, nobody's quantifying it. They do. We don't know what best processes are. We don't know how to get those kind of results. This is the premier hospital demonstration project. Three papers have been published. Now, do you want patients with a heart attack to get all the 5 things they ought to get? Well, sure you do. But what they found is that in hospital, the 5 measures for heart failure, which are proven by clinical trials to be effective and you would want, are really not associated with a decrease in mortality rate. That means there's a lot more going on here. Same for heart attack, 6% of the difference among hospitals and mortality rate. There is some improvement in pneumonia, but it's 7.9 to 7.2% if you get the 3 things you ought to have for treatment of pneumonia. Meaning our understanding of best processes is pretty primitive. So that's hospital efficiency. What about primary care? I'm dealing with 2 issues, chronic disease management and inefficiency in hospitals. I'm not dealing with imaging or unnecessary procedures. This is chronic disease management. Without primary care, you have no chronic disease management. So what's happened to primary care? 30% of the country are primary care doctors, and every other industrialized country is 50% of the workforce. What I can tell you is the doctor-patient relationship is absolutely gone. It's very different from when I was a kid. I won't go into why. The average Medicare patient has 5 specialists, 2 primary care doctors. This is self-management. You pick your doc. Who do you think you need to see? Nobody knows what's going on. What do you expect? The emergency department problem, in my view, is 3 things. Too many uninsured people, lack of good primary care, and probably some inefficiencies in hospitals. But I think primary care is the biggest driver. What are happening to primary care docs right now? The ones that can are saying, I'll take care of you at a commercial rate, you bill insurance. It's for rich people only. So we've got a catastrophe going on in primary care. No possibility of reducing chronic disease costs without fixing this. Well, why is it primary care? This is maybe the most important graph in healthcare policy. These are all the states, and this is the per capita cost of caring for Medicare patients by state. And on this index are quality measures, mostly primary care quality measures. And what was found, here's old Texas down here, high per capita cost and low quality. And up here, Utah, Wisconsin, Midwestern states, low cost, high quality. What's the variable? It's primary care doctors. The more specialists, the lower you are on this graph. The more primary care doctors, the better you are on this graph. So how do we get that money back and improve quality in the deal? I love telling this story. I talked to friends in Houston. They told me that they had friends in Tennessee. I flew up there, been there twice, and met with the doctors. This is a clinic of 1,400 Medicare patients, Medicare patients, in Sumner Clinic, Gallatin, Tennessee. They've got most of the town that's in Medicare in this clinic. 12 doctors. And a series of negotiations went on among the insurers, but the end was the docs got paid a 30% bonus if they could reduce the cost of care, if they could bring their quality measures from 40% to 90%, and have good retention in the practice. The docs thought, I think we can do that. So what did they do? Well, it started in 2003. Within 2 years, they had dropped the medical cost of care from 87% of payment to 69%, basically 20% reduction in cost of care. They did it by decreased admissions to the hospital, decreased ER visits, and we're at the 90th percentile, not just on process measures, but on outcome measures. Was blood pressure controlled? Yes. Was glucose kept in normal ranges? Yes. How'd they do it? This is best processes. They found out, just by trial and error, this was no trivial undertaking. About 40 minutes a patient was required. They had to collaborate with nurses and pharmacists for patient education. They had to be available 24/7. The clinic was the first point of contact with the medical system, and they paid a lot of attention to detail. So you can do this. It was for both LDS Hospital and Gallatin Clinic. This was a new business model. This was not tweaking the existing business model. This was a change in everything they did with capital infusions to do it. How do we do this nationally? It's got to be hospital by hospital and clinic by clinic. And you're saying, how is that possible? It is possible because Deming, the person that reconstituted the Japanese economy after World War II, one of his business principles is if you want to turn something, or change something, you turn the square root of the number needing change. If you've got 9 things you want to reform, you pick 3. If it's 5,000 hospitals, you find 64. So the short answer is you're going to have to do it hospital to hospital, clinic by clinic. You change the culture of medicine, it will spread. Docs and hospitals want to do the right thing. It's got to be all payers. You can't go to a hospital like Gallatin Clinic said, we want you to do this cool program we've got with 1/3 of your patients. It doesn't work because you're seeing the other 70% every 5 minutes. It's got to be the whole thing. So sad news, all payers. It can't be done on the cheap. You've got to have administrative support. The high-performance providers are going to have to teach the others how to do it. You got to anchor one patient to a clinic. You can't have patients wandering the street and expect any doctor to be able to manage it. You don't know what's going on. You have no control over it, and you don't know who to tag for quality measures. Who didn't give the beta blocker? You know, if they're seeing 3 docs, who do you tag with them? If there's really 30% savings, you can pay a patient to see one doctor. This has got to be voluntary, and you've got to use the benchmarks to establish payment policy. That is to say, I think you combine comparative effectiveness research with payment experiments. You can't divorce them because the benchmarks will be ignored as they are now unless they affect payment. It's all the same process. So the answer is this is going to take some time. It's a change in culture. We've got less than a decade to pull it off. Primary care is fast eroding. We better send a strong signal we're going to reconstitute it. And my own belief is that what you're seeing on the financial markets, you're going to be seeing in medicine within the decade if we don't do something pretty quickly. So I'm for a single entity that deals with standards, processes, and payment policy. Thanks.
Well, you can see why, guys, my favorite neurosurgeon, he's in a hurry to fix the system, so I like that a lot. Okay, let's open it up for questions, and I wonder if, do we have a microphone? Or, okay, we'll just, when you stand up, it would be good to announce who you are and tell your affiliation if you indeed have one or two or three, whatever you. Well, while y'all are formulating your own, okay, go ahead, do it.
Andy Rock, HHS ASPE, the Planning Evaluation Office. I guess I'm to you in terms of this issue. I was curious about the link between quality and the kind of all the hoopla about pay for performance. And it seemed like you're sort of addressing it, but I guess I'm just curious what you would say to the people who are sort of pushing pay for performance as a kind of, individualized docs, because it seems like you have a very different story, and you were sort of touching on it. I wonder if you could talk a little bit more about that.
Hospital pay for performance right now is, the pay is 1.5% bonus and the penalties, I think, 0.4% for not reporting. You talk to hospitals and it covers their cost to report, the 1.5%. It's actually completely revenue neutral. What I found out is when you went into hospitals, the limited looking that I've done, in trying to find really best performing hospitals, there are not tons of them around. They're investing huge sums of money into changing their operations. I mean, this is culture change, low nursing turnover rates, and how do you get low nursing turnover rates? Yes, information systems, but mainly standardized protocols. Somebody's got to watch those protocols, because if you don't watch them, they don't get done. So, I think we have to be doing what we're doing, but what we're doing is paying people 1.5% to do what they ought to be doing anyway. You ought to be able to give beta blockers, aspirin. This is normal medicine. Nobody ever looked. It's good that we're looking, but you can't make the structure. The changes need to be structured. You need to embed payment into quality so that it literally transforms the industry. You create a business case for doing it right. And what you do is you put about a third of hospitals out of business, which isn't so bad. You put the right third out of business. Or they change. I mean, they do things, and the whole idea with primary care is to keep people out of hospitals when they don't need to be. So I don't think these pay for performance programs are just sort of nibbling around the edges of this thing. It's the right idea, but not taken nearly far enough. It's got to be fundamental payment change. And I think doctors will do this voluntarily. You don't have to. You came to me with a deal. You practice really good medicine and I'll pay you more profit. I take it.
Marcia, you want to talk about when in your communities?
Yeah, I think that we basically come to this from the same point of view. So pay for performance right now, I think it's a marginal kind of attempt. And I think if you pay for performance at the margin, you won't change the structure and the delivery of healthcare. I think all of us are saying the same thing. And the question, someone said earlier, what are hospitals going to look like in 10 years? What is the healthcare delivery system going to look like in 10 years? You can't fundamentally restructure the payment system without fundamentally restructuring the delivery system. I'm not so sure. I think doctors are going to be thrilled to join this. I think that doctors feel they haven't been part of the discussion up to now, that they're not helping to define in a systemic way what quality means. I think sometimes they can feel this is foisted upon them. And so if that continues, I don't know that you'll get that uptake, of some of these measures. But, I think the concept of pay for performance is just the most normal, sensible thing. It's all the devil is in the details.
Brent, you were...
Yeah, I would say maybe it's a different way of saying the same thing, but I think the current structure of pay for performance is helping in the area of reliability. And some of the data that Marcia showed helps us in that regard. In other words, can we reliably deliver a bundle of services related to acute MI care? And of course, variability is one of the things that's plaguing the healthcare delivery system. So I think in that sector it's helpful, but it is not flipping it into paying for value and overall value. And I think that's the transition that needs to occur, and I think it's going to be the next generation, but it's a step in the right direction.
Hi, I'm Carolyn Poplin, and I'm with Georgetown. And I'm a physician, a primary care physician. Wenberg has shown that a lot of medical care is supply driven. So that's at a much, you're talking about care at the point of service and how we're going to change the payment for that. But decisions are made much earlier as to whether a doctor will become a specialist or a so-called primary care physician. Once you have too many specialists, then you have too many specialty procedures, and changing the reimbursement a little bit then won't change the ratio of specialists to primary care physicians, because they made that decision 10 years before they get to the point where you're now paying them a little more or a little less. So how do these measures take account of that?
Well, we got two academic docs here, so how you guys doing recruiting people to?
And that's true for hospitals too. In other words, it's not profitable to run a psychiatric hospital for geriatric patients. So you didn't have any beds for that. But if you had a cardiac patient who needed a bypass, I'm sure you would have had beds for that. And you don't have enough beds, but in Boston, they have too many beds. And someone said, you know, a bed built is a bed filled. Once you build it, you've got to fill it. So that's another supply problem. And none of this deals with supply of doctors, supply of imaging equipment. Once you've got the CAT scanner, you've got to use it. You have to pay for it.
So I would just jump in and say, I think most of us agree and understand that there's a pretty wide body of research on that. And I think but it does, in my mind, I think raise two issues. We completely agree that you have to strengthen the primary care system on the front end in terms of workforce and profitability of primary care, which is not there now. And that, again, points to redesigning a payment system that rewards primary care. And I think we'll start to shift the economic dynamics around specialty care if the root payment system is redesigned, as opposed to, I think, the point you're raising, which is tinkering around the edges of the current payment system. But I think it also raises, everything is interdependent. I think it raises a critical issue, which is that if you look at the work that Geisinger has done in primary care, right, where they've organized around a medical home concept, and they've been able to strengthen their primary care system and decrease hospitalizations by 30%. Now, when you look at it, that sounds really great, and maybe that helps with the overcrowding issue. But in the end, where is the business model for hospitals? Because 30% are not going to go out of business without a fight. And if we're in the context of health reform debate in the political and public policy arena, you cannot leave one major and powerful stakeholder out there without looking at, okay, how do we shift the business model that makes it okay for you to change, and that drives you to change, and that holds you accountable, but that also shares some savings as well. So I think it's a very complicated issue, and it's very interconnected.
Yes, in the back.
Steve Cranston, and with the RNs Working Together, which is a coalition of AFL-CIO unions that represent registered nurses. And when we begin talking about the quality debate, one of the areas that sometimes gets left out is workplace issues, specifically registered nurses. There's a well-known shortage of nurses, and that impacts quality of care, medical errors, and so forth. And for our members, one of the solutions, one of the real problems that they see is having not enough nurses providing care, which impacts errors. And one of the solutions that they've been talking about, and we have legislation for, are minimum nurse-to-patient ratios, that mandatory minimum nurse-to-patient ratios that hospitals would have to institute. I'd like to hear your view on that.
First of all, emergency medicine is all about practicing as a team. I mean, our nurses, I mean, I can't count the number of times that my nurse colleagues have helped bad things from happening because they're there. So it's wonderful. I think from an emergency care perspective, I certainly support the concept of having minimum ratios. The problem is that you can enforce them everywhere, but somewhere it's got to give. And where it gives is in the emergency care system. So you have patients who sit in the emergency department and a nurse taking care of, and this is, I mean, literally stories, I've heard this many times, where one RN is taking care of 6 to 7 patients on ventilators in the emergency department while a bed sits empty in the ICU, and you can't transfer any of those patients up to the ICU because you'd exceed the minimum mandatory nurse-to-patient ratio. That's when it doesn't make sense anymore to me. So we're going to have 6 or 7 people on beds down in the ED hallway, cared for by one RN, when there's an empty bed and a nurse upstairs taking care of 2 to 1 or 1 to 1. So you understand what I'm saying? If there's not enough nurses, then where do you give and how do you distribute the load in a rational way? So I support them. The reality, though, is there's going to be times when there's more patients than you have nurses. And so how do you distribute them? And that's the challenge.
That's a very bad thing that's happened to patients in wards where there was a high nurse-to-patient ratio because of essentially lack of education. Had some very good things happen to patients in units where there was not a high nurse-to-patient ratio because you had very seasoned, very knowledgeable nurses. I don't think this has worked out well for California. I would approach it in another way. If you talk to people in the hospital quality business, they'll tell you if you had to ask one question at the door of a hospital to answer whether you want to be in this hospital or not, it's what your nursing turnover ratio is. It's retention of staff. Yeah. And I don't think these ratios recognize this. I mean, if you've got a lot of nurses that don't know what's going on, you've got a problem. So, the nursing shortage, which is, I think, probably the single biggest hospital quality issue there is, if I had to pick one, is artificial. In 2005, there were 100,000 qualified applicants for U.S. nursing schools, 37,000 returned away. And the reason is they weren't willing to pay probably 15% extra for nursing masters and PhD level teachers.
Exactly, yes.
This is crazy. So this is really about physician-nurse relationships. It's about workforce training. I think that's where the focus needs to be, not on setting arbitrary numbers.
So maybe we should all agree to get CMS to add turnover ratios to the collection that we're reporting in hospital compare. Anybody else? Yes, go ahead.
Well, you're absolutely right. I'm a nurse practitioner. I've been a nurse for 40 years, and I'm working with the National Education Association right now. But if I were a nursing instructor and I had a group of students, when they walk out my door as graduates, they would make twice as much as I make. What's wrong with that picture? And I absolutely agree with you. There is not a shortage of nursing candidates. There's a shortage of well-paid nursing instructors. And so again, it goes back to education, not only for physicians, but nurses and qualified mid-level practitioners.
And if you follow the money on that story, I read one paper that estimated that about 10% of hospital costs in the last several years have been related to nursing shortages, which I believe you did that number and then looked at what it would take to pay nursing instructors. The leverage on that is off the chart.
Exactly. Why don't we do that study?
Yeah. All right. We'll go back to this. Any more questions? Yes, go ahead.
There's a school of thought.
Could you stand up, please, so
Sure.
we tell us who you are?
My name is Lincoln Weed. I'm a employee benefit lawyer here in Washington. There's a school of thought that healthcare reform in general and taking advantage of health information technology in particular is never really going to make much progress until medical education and credentialing are reformed very dramatically. The problem is that doctors are not educated about standards of care for managing clinical information. What's missing is something analogous to accounting standards for managing financial information. And some would say that the lack of analogous standards for clinical information is the root cause of failures of quality and economy in the healthcare system. So I'd be interested in any of your responses to that concept.
Not computing.
Pardon?
I don't understand.
I think Chris
Well,
was trying. Okay, Chris.
Do you understand?
Yeah, I mean, I think what you're saying is that part of how we drive effective health reform is leveraging information technology, and how we drive leveraging information technology is reliant upon medical education, helping doctors understand effective standards for information management. Is that encapsulated?
Right, and specifically the kind of standard that I'm talking about, how data is organized in medical records, and how medical knowledge is applied to patient data in terms of choosing and selecting.
Yeah, I agree with that. And so I'll say this is with a background from the eHealth Initiative. But I mean, I agree that those are critical areas, but I'm not sure that physicians are the right target necessarily as the frontline clinician that needs to be aware of how clinical data is managed and stored. I mean, I think there is a cultural shift that is happening already among physicians using health information technology, and it does help that many medical schools are incorporating HIT into their clinical education. But I think it's a much more complex problem that absolutely relates to the lack of incentives for the bulk of doctors already in practice to invest in systems. They should absolutely have staff who understand information management and organization from an electronic clinical perspective. But when we're asking doctors to really provide, high quality care, I'm not sure we want to overburden them and ask them to also understand how the technology is organized, but rather how to effectively use technology to provide decision support and other tools to help them organize their care. So I understand, I think, the question and the concept, and I think it's an important one, but I think it's related to payment system. I think it's related to capacity. So I think there are a number of other issues that probably drive that in addition to medical education. That's my take, Guy. I mean, you guys are real doctors.
I would just say it's a lack of system thinking. I mean, the way I was trained, the way we train people, and nobody's trained in system thinking. I think that's the issue. There really isn't a business case. I keep telling people there's no business case for IT. If there's no business case for efficiency,
That's right.
why would you bother with it? That's the problem.
And I think we have a number of examples of really stellar primary care docs and others who are incredibly adept at leveraging and utilizing technology in a very systems-oriented, high-quality, high-caliber, and efficient way that absolutely don't have the medical education background, but we have a number of resources assembled to support their care, but they're losing money right and left because the payment system is aligned toward volume and not necessarily outcomes.
The only other that I would add beyond systems is systems and teams. It's multidisciplinary teams, and what the future is, and the possibility from a HIT platform that can coordinate multidisciplinary teams. We're not trained in teams. We train in our own little disciplines, and there's another potential for the future is how we train together with other professional mid-level providers, our nursing colleagues, physicians, and people that can use the tools to help coordinate care that are much less costly that's terrible physician work, as you look towards the future, and I think that's another area for potential at tackling some of these quality and cost issues.
To pick up on what may be a corollary, I was really struck, Marcia, in your talk about how the physicians you're encountering out there in the quality initiative in the field, so to speak, sort of resent or are afraid of or don't like the quality measure, quote, being forced into appointment. Yet, those of us who live, inside the Beltway sort of think, well, didn't it come from the National Quality Forum? Aren't these things all worked out by the Specialist Society, American College of Surgeons, et cetera? Maybe there's something about the disconnect between the information sophistication and the measurement that is, quote, being foisted on them. So could you speak a little bit more elaborately about what they're really saying and what can we do about the fact they don't like what we all agree they should be measured?
I'm not so sure that there is discontent with any one particular measure. I think there's a sort of sense of bundling these measures says something about the overall quality that these physicians are providing, and that it's not a good reflection necessarily of how good of a doctor someone is. so that it's really sort of picking one thing from this list and one thing from that. The other thing is that I think that physicians want to make sure that they're being judged on what really they can control, as opposed to what a patient can control. And the other thing is that, someone brought up workforce before. This, the physicians, the nurses, the techs, everyone, they're the army out there that are sort of fighting the war. And I think that sometimes policy can, even through working through medical societies or other interested organizations like NQF and others, they can not necessarily do the legwork to make sure that the community physicians and others really understand the reasons for doing what we're doing. And, it's sort of like the perfect being the enemy of the good. It would be better sometimes to even get groups of physicians and others to embrace a sense of, using data for quality, even if there were fewer measures, or even if they were, looking at slices of their practice. So I think it's a sense of being judged on some external values that, while individual from an evidence point of view, they understand, but really don't think that's what they do, every day when they go to their practice.
Great. So it's not just medical education, it's also communication rather than
Exactly.
She's right on. I mean, I agree with everything you just said. But the other part of, in addition to that, the other part of that NQF process and the RUC, all the different things, that's hardwired in addition to paying for volume is this concept of a fixed pie, where if I win, the dermatologists lose, or hopefully the neurosurgeons lose. If I but that is so hardwired in the process currently that it's everybody's sort of defensively posturing to make sure that it doesn't affect their slice of the pie. And in addition to everything that Marcia just mentioned.
I think there's one more thing that's missing, and I say this as a practitioner. No one ever asks, why aren't you doing it now? If this is standard of care to get a hemoglobin A1C every 6 months, why aren't you doing it now? Things happen for a reason. I mean, someone in the IOM said every structure is perfectly designed to produce the results that it produces. There are reasons for that. I would say some of it has to do with coding, which is dictated to us, and it's based on acute care. You have one chief complaint, and that's what the patient comes in complaining of. He comes in complaining of arthritis. It's not what you can do about that. His real problem is diabetes. but you're filling in an electronic medical record that says chief complaint, history of present illness, that's the arthritis, and the diabetes and the hypertension and the pneumovax, that's all in the last third. It amounts to no more than 1/3 of the present coding system. That's one reason things happen that way. We are also trained to react. You don't tell the patient what the agenda is. The patient tells you what he wants help with. You have to look at the record beforehand to figure out not just what he wants, but what he needs. And you don't get paid for that. So you have to ask people who are trying to do the best they can, why don't you do these things? Is it because you didn't know? Is it because you didn't have time? Is it because you didn't get paid?
And can I just add
Sure.
one other thing? Just in terms of medical homes, which is sort of a very interesting and very powerful concept, I think. There is some concern that primary care physicians are just going to be saddled with a new set of requirements with relatively little compensation, and that sort of the burden of covering all this kind of illness and care is just sort of wrapped around that concept.
Great. Well, join me, Justine, go ahead, you take the last question. Go ahead, we got it. It's Friday, we can take one more.
The thought that's going through my mind is that I'm a forward-looking person, and I see that we've been coming from specialization, we've been coming from acute care, we've been coming from these people that we spend all this money on, and we need to go to war. An understanding of what keeps somebody well, and attach that to the medical home. And maybe even have some NIH research on wellness, because as I read the cutting edge stuff, it seems to me that some of the things that you do for cancer are things that you do for heart, cardiac, and so forth, and we're beginning to understand that there are things that have very high payoffs in that regard.
Well, from a patient perspective, which I always like to end on,
Yes, yes.
I think we couldn't agree more. We do need to understand what drives wellness, and we need to pay for it. And I think that's why I would pick up on something that Marcia talked about, which is the tension that physicians have over what they can control and what they can't. And wellness is an area that has huge dimensions of I can't directly control that, but the patient can. So that being said, while I think we absolutely need good risk adjustment and appropriate risk adjustment methodologies for these measures so that physicians aren't unduly penalized, but I think we absolutely need measures that are shared accountability between physicians and patients, because I spent a year researching doctors to find my own, and I've got one. I went on health grades, I got public reported data, I got one with an EMR. Have I heard from that guy in 2 years? No. And so, you know,
Well, send him an email.
no, but I mean in terms of prevention and wellness, you know, and so, but if he were accountable with me, you know,
Yes.
for like the whole picture of wellness, I think the behavior is different. Now, you don't have to put 50% of the payment at risk, but I think with some sort of bonus or other structure that is an add-on for wellness is absolutely appropriate. So my 2 cents in soapbox.
Well, thank the panel, thank Justine for bringing us back. And this is the first of many conversations, clearly. Thank you so much for coming.